pleasure to be here today. My name is Mamoun. As Paul has described, I work at the Royal London Hospital in central London. And I'd like to explore with you your understanding of the science of resuscitation. Describe to you our current understanding, where medicine sits today, and where we might be heading in the very near future, or already practicing and pushing boundaries today. In the purest sense, resuscitation refers to the process of supporting the heart and lungs. And most people refer to resuscitation based on what they commonly see either in TV dramas or, for that matter, perhaps in, hopefully, real-life attendance at basic life support training. The chain of survival, as we've known it for many years now, involves the recognition of someone whose heart has just stopped as opposed to just fainted, proceeding to give them basic life support with compressions of the chest predominantly, and perhaps some breaths, and arrival of an ambulance team of some configuration that then delivers either the electric shock that Paul has described, or for that matter, a more advanced therapy, as we'll explore later, and then arriving with the patient at a center that's able to perhaps reverse the event that primarily precipitated the cardiac arrest, or carry on the ongoing care of the patient if the team on scene has been successful in resuscitating them. More broadly speaking, resuscitation nowadays is considered to be the combination of therapies that are given to a patient who is critically ill. That is to support their heart, lungs, kidneys, brain, or any of the above. In parallel to that, I'd like to describe our current understanding and working understanding and practice, for that matter, as regards death. Death is complex. Death has huge psychosocial impact. There is a not insignificant, globally, religious, spiritual component that invariably influences people's understanding, people's views on death, people's views when death has actually occurred. And there is a clinical definition that's not far off what Paul's described, which is essentially an unresponsive patient who has no respiratory effort, so is not breathing, and has got a pulse that's absent, and perhaps in some systems, heart sounds that are not audible. In some other systems, electrical activity that's of a particular pattern on an ECG. If you notice all the points I've just mentioned, essentially, beyond basic signs of life, what we're focusing here is the heart. I'm going to put to you some scenarios that even today challenge that definition. Consider this. The images don't relate to the patient that I've treated, but rather to a public figure who collapsed while playing a Premiership football match in the UK. But the player receiving treatment while a few years older was indeed in cardiac arrest and was receiving resuscitation in front of the 40 or 50,000 people in the stadium. Consider a 17-year-old that either I encounter in the pre-hospital setting or was brought to the emergency department who was having some sort of physical activity, has a sudden, unexpected cardiac arrest. Think of that patient. Until that moment that child or adolescent's heart stopped, every other organ was presumably functioning normally. That's assuming the cardiac arrest was indeed related to the heart stopping or heart disease. But the assumption is that every other organ was functioning normally. Let's go with this hypothesis that every other organ was indeed functioning normally. If we were to physically be able to replace that heart, hypothetically speaking, with an artificial pump in a brief period of time, perhaps the 4 or 5 minutes period of time, that we know is key to the patient patient's brain not suffering a consequence or minimal consequence from the cardiac arrest. So if we're to click a finger and get that heart working again, that patient theoretically should survive. Most likely cause of such a scenario is primary disease of the heart. And it's for that reason that I put the hypothesis. So in that age group, it's often due to heart disease that's previously not been diagnosed. Either structural heart disease that essentially has rendered the heart a little bit thickened, pumping fairly ineffectively, and following or during strenuous physical activity as a complete sudden event, the heart suddenly packs up. Another not uncommon scenario is a familial type of abnormal electrical activity that goes through the heart that essentially results in the same thing. In both scenarios, every single other organ of that patient would have been absolutely pristine. Coming back to the psychosocial, emotional aspects of death, and that's not insignificant on why we're pursuing this. Imagine being the clinician in the resuscitation room breaking the news to that patient's mother. It's fairly unpleasant to lose a young friend, maybe a young relative, maybe spouse. But let me tell you, there is nothing, absolutely nothing worse I've experienced in my 16, 17-year medical career than telling a mother that her child has died. And I can assure you, like many of my colleagues in this field of critical care or resuscitation or emergency medicine, that is a huge driving force to push the boundaries. Picture another scenario. 45-year-old lady, mother of 3 kids, out of the blue, standing there cooking or at work or doing whatever, has a sudden collapse. She doesn't lose her immediate signs of life. She continues to breathe, perhaps requires a little bit of support with the breathing from the ambulance crew, but continues to breathe. Her heart certainly continues to beat. She's been brought into the hospital in a deep coma. Then has a procedure perhaps to support her airway and her breathing to minimize the consequence of what in that pattern we recognize to be a likely neurological event, broadly speaking. And most clinicians would recognize this to be a stroke or an internal bleeding in the brain or something of that nature. In that pattern, in that profile, as most of medicine is pattern recognition, frankly, of a sort, you undertake a number of procedures to minimize the consequence, and then you do a scan. You do a scan, and you see a catastrophic internal bleed in the brain. 24 hours later, this patient has no brainstem reflexes, as we now describe them. No signs of life other than the ventilator no signs of life other than on the patient's own autonomic or automated mode, heart beating, frankly. And the ventilator is keeping the body oxygenated and clearing CO2. And therefore, you've got a heart which in that instant will be beating as effectively, if not more effectively, than any other patient in the intensive care unit who's receiving perhaps no support for the heart whatsoever, but who has no signs of life in terms of brainstem definition. Which one of those 2 patients is dead? This is the challenge. Because strictly speaking, in that moment, when you're doing the assessment instantaneously, you'd have to say the 16-year-old or the 17-year-old kid who's dead. In reality, we know that in today's medicine, if a patient has tests positive for brainstem testing, i.e. fails every single brainstem stimulation test, and is repeated on another occasion by another clinician completely independently, and then the patient once again fails the brainstem test. In today's medicine, we know that to be a completely irrecoverable state, and in most healthcare systems, that results in informing the family of that and proceeding with withdrawal therapy. I'm not going to, for the purpose of this talk, go into the widely popularized 1 in a million and 1 in 10 million stories of someone waking up from a coma after 5 or 10 years, not merely because it's a distraction, but I'm more than happy to take questions on those topics. In our system, and specifically 25 years ago, a group of clinicians decided that the frequently occurring young patients who are having sudden cardiac arrest from violence-related trauma and who are bleeding internally around the heart can benefit from a roadside open heart surgical procedure that by many was considered futile in the pre-hospital setting, that today saves 1 in 5 people. And frankly, if we compare that to the medical causes of cardiac arrest, we have probably moved very little in the science and medicine of resuscitation in the last 25 years. Why is it possible for me today to attend one of those patients from violence-related trauma or otherwise, within a few minutes of the onset of their cardiac arrest, conduct field surgery and anesthesia on them, and have, in entirely unpredictable circumstances, favorable outcome? Yet, as far as medical causes of cardiac arrest is concerned, primary disease of the heart is concerned, we're still dependent on the patient having a return of his own circulation, perhaps if they're fortunate enough to get to a cardiac center to carry out a procedure to unblock an artery. While in reality, if we could buy time for those patients, what's required to reverse their disease is far simpler. Provided the transport mechanism either to bring the expertise to the patient is available, and we're very fortunate to have that in and around London, and for that matter in many cities in Europe, then it should be entirely possible to offer something new for these patients. Something that I will try and put to you challenges our definition of death. The case that you're about to see involves a young patient who had a sudden, unexpected cardiac arrest on the streets of Paris. And through a lot of work by many people around Europe and across the Atlantic, over 160 patients have now been resuscitated or had attempted resuscitations on the road with this procedure. Many more, over 2,000 in the hospital setting. The procedure involves making a dissection in either or both of the groins, accessing 2 blood vessels that you can see up on the screen, which are the which is the fastest access to the major blood vessels coming out of the heart, using 1 catheter or vascular access device, so to put it, the size of a hose pipe, I might add, to remove a significant quantity of blood per minute from the patient, pass it through a device that provides oxygenation, and then actively pumps it to the opposite side of the heart, opposite side of the body rather, in a retrograde or opposite fashion to what you might expect, fully oxygenated. What that allows us to do is replace the heart function almost entirely. And what that does is bias that bridge of time to A, work out what it is that causes the cardiac arrest, and B, have the opportunity to do something about it. This is not fictional work. This is work, the product of which, depending which series you refer to, up to 50 or 60% of patients may walk and go home. Don't take it in a simplistic fashion, and I certainly am not attempting to make it sound really simple to put someone on heart bypass on the road, or even in the resuscitation room, or even in the cardiothoracic theaters for that matter. Far from it. And it's probably the combination of technology and, more importantly, technical expertise required and proximity to the patient that's today spreading this technology from being more widely available. Nonetheless, it offers a huge opportunity. Just talking through the video of our case there. So what we've achieved so far in the few minutes we've been talking is we've put the first access device into the one of the two vessels. I think it was the venous side, so probably the blue vessel on the screen. And we're about to insert the second device over the wire into the arterial side. So this small piece of plastic is merely making the hole slightly bigger, and it will be followed by a bigger device, and essentially, by the time both of those devices are in, the patient will be connected to the pump, and you'll be able to see oxygenated blood entering the body again, completely independently of the heart and lung function. I'll come back to the video in a second. In the interest of sticking to time, I'm going to move on. How does this happen? I've referred earlier to the technical expertise required, but a huge amount of training, rehearsal for that team to function either in a resuscitation team or at the roadside with a degree of safety and efficiency for that not to be considered maverick work. And that's absolutely fundamental. But make no mistake about it. This allows a patient who would otherwise have no blood pressure, no pulsatility and no blood pressure at all, to have completely normal oxygenation to the brain. It allows patients without a heartbeat to be having a completely perfused brain. And this is taking place in many centers around the world today. I'm very proud to have been part of the team that's delivered this in the pre-hospital setting. But this is absolutely fascinating technology with a huge potential. This is the layout or the configuration of the team that takes place. You can see 2 senior physicians are required. Someone who's controlling the patient's breathing and support. And throughout the process, the patient's heart is being supported by the basic life support, or an automated device, essentially, that's achieving the chest compressions. But it's this that allows us to, instead of having that deeply unpleasant and without a doubt a experience that very few of us ever forget, that conversation with the child's mother, that instead of saying your child has died, at least we're able to say we're offering some support for his heart. We're going to try and work out why this has happened. We hope that we have placed him on support within a period of time that's conducive to survival with an intact brain function. And we've truly done everything we can. We've truly done everything we can. Now, as you can see, that does raise the question. Which of those patients that we've described is alive? The patient whose heart has been stabbed, yet if I were to remove that knife, remove the blood collection around the heart would automatically restart. Yet I have the challenge of needing to do that procedure in a few minutes. We've been doing that for 25 years, and that should be absolutely possible. Or a patient whose heart has stopped, and now we're pushing the boundaries further, who, because they've lost a significant blood volume, it would be challenging to apply the technique that I described earlier, but instead we still want to look for a form of support. Colleagues in Pittsburgh have already completed the planning phase of a trial. I'm not aware of any human recruits into the trial yet, but a huge number of animal studies have been done that have successfully, within a very brief period after a trauma patient's heart stopping, have replaced their blood volume with a super cold solution to preserve the body, and I'm going to move away from the sci-fi suspended animation expressions now, to preserve the body, to buy the surgeons enough time to repair what would otherwise be a fairly simple injury to repair. We look forward to the results of that trial. The intent is to recruit 10 patients. We're certainly doing work in London to plan work in parallel to that, and I hope I'll be able to convey for you the updates on that in the near future. But like I say, in the animal studies, as many as 90% of the animal models have gone on to recover. But is this shocking? Not entirely. In cardiothoracic surgery, specifically in pulmonary trunk surgery, so surgery around the arteries that supply the lungs, we have needed to do a form of suspended animation for many years. For surgery that repairs the major blood vessels in the body, we have needed to do what we call deep hypothermic circulatory arrest for many years. It's considered routine elective surgery. And if someone were to come in and have that in an elective basis, you would, in the process of consenting them, be informing them while there are some risks associated, you would almost certainly expect them to survive and recover from that. So why not extend that to the emergent setting? Of course, there are challenges to the emergent setting, and ones that I've outlined earlier, to make sure when you need the technology, it's there. When you need the expertise, it's there. But this is entirely possible. How far is it from our system elsewhere, other than Europe or the US? Well, the one point I want to emphasize in relation to that, for all of that to be possible, you would need a level of compliance with bystander CPR, layman-offered CPR, layman-offered resuscitation, to bias their first 3, 4, 5 minutes, far more than is currently possible in most countries, and far more than is desired, frankly, with the exception of Seattle, perhaps. And I'm glad to say, many of the stories I've referred to earlier, there were some happy endings, but there's far more work to be done. Are there any conflicts with religion in relation to that? I honestly don't think so. I work in London. Like Dubai, it's one of the most diverse cities in the world. Yet, in 16, 17 years of having resuscitation-type discussions with patients and their relatives, I've never encountered that to be a challenge. I find that clear communication, a clear explanation of our limitations, a clear explanation of our understanding, and a clear, expectation outline from the outset resolves that, putting things exactly as they are and not discussing areas that we have neither no knowledge about or adequate information about, and rather stating that quite clearly. Ladies and gentlemen, I'm not going to take any longer. Thank you very much for listening. It's been an absolute pleasure.